Thank you for joining us for today's webinar on RECIST 1.1 and oncology trial endpoints. In this seminar, we'll be discussing the principles of RECIST 1.1, the information needed to collect imaging endpoints and special considerations while using the RECIST 1.1 criteria. I would like to introduce our speaker for today, Dr. Jean Kim. Jean is Merit's clinical scientist. He implemented the RECIST 1.1 and other reading criteria into our Excelsior software platform, delivering automation in a single system for all image and workflow management. All participants will be muted during the presentation. However, we will have questions and answers at the end of the presentation. Please feel free to send your questions via the Zoom chat function prior to the Q&A session. Without further ado, please welcome Dr. Kim.
Thank you for the introduction, Shinji. Hello, everyone. Today, I would like to talk about RECIST 1.1 and oncology trial endpoints. All right, so we'll be going over guidance provided by RECIST 1.1, including conformance rules and important information that needs to be collected while performing RECIST 1.1 based studies, and how these translate into imaging endpoints. Also, we'll be discussing several special cases of RECIST 1.1 and common mistakes avoid. For the purpose of the RECIST 1.1 is to provide the objective method to set the outcome of the how subject's tumor response to the cancer therapy. Getting into more in-depth part of the RECIST 1.1, this criteria uses unidimensional measurement, which would mean long axis of non-nodal lesions or the short axis of the nodal lesions. So simply a distance is measured to calculate the outcomes. And also, the measurability of the lesion is defined by the RECIST 1.1, which would be a longest diameter of at least 10 millimeters by CT scan with a 5 millimeter slice thickness. And if it's a malignant lymph node, it will have to be at least 50 millimeters in short axis by CT scan. They also recommend that if the slice thickness is greater than 5 millimeters, the size requirement would be double the slice thickness, which should mean if the slice thickness was 10 millimeters, the minimum size requirement will become the double size, which would be 20 millimeters of the longest diameter. And also, the definition of the non-measurable lesions would be all other lesions that do not meet the measurability requirements that we just discussed in the prior slide, which would also include the small lesions, the lesions with the longest diameter less than 10 millimeters, or any malignant lymph nodes with the short axis less than 15 but greater than 10. And also, any truly non-measurable lesions were defined by the RECIST 1.1 guidance, and those are the lesion presentation type that truly makes the reader difficult to give an accurate measurable or the quantity of the lesions. And those are included in this list here. Method of the lesion measurements are also recommended by RECIST 1.1, and it would be the consistent method of imaging acquisitions from the baseline to the end of the study. Preferred modality recommended by RECIST 1.1 is the computed tomography, and secondarily, the magnetic resonance imaging is recommended, with the appropriate and consistent imaging parameters should be kept. Other modalities like clinical exams, chest x-ray, ultrasound, endoscopy, laparoscopies are not recommended, and it's only to be used as an auxiliary just to provide an additional information to the reader, but it's truly not supposed to be used to derive any response criteria recommended by RECIST 1.1. And also RECIST 1.1 guides to group lesions into 3 different categories for assessment at each time point, which will be target lesions, non-target lesions, and the new lesions. Target lesions and non-target lesions are lesions that are defined at the baseline, and new lesions would be any new metastasis arises upon follow-up visits. Target lesions are a quantitative assessment. Non-target and the new lesions would have a qualitative assessment. Getting more in detail to the target lesions. Target lesions would have maximum allowed of 5 lesions from a measurable lesions per subject. So the target lesion has to be measurable, which would mean longest diameter has to be at least 10 millimeters or greater, or the short axis of 50 millimeters or greater if they are the nodal lesions. Also, the RECIST 1.1 recommends that it should not be more than 2 lesions per organ. And the target lesion should be selected based upon the size and the reproducibility and being representative of the involved organ at the baseline. And for instance, the reproducibility wise, it should be selected based upon how reproducible the lesion itself would be. So one additional consideration for reproducibility would be picking a target lesion in a more stable location rather than any locations that move frequently, which should be outer lung area or any intestinal area would be more likely to have a less reproducibility to those lesion shape. For the target lesion assessment at the baseline, these are the information that would be recorded by readers. Lesion measurement in millimeters. Longest diameter of non-nodal or the short axis of the nodal lesion should be recorded on the form. And the lesion state would be recorded as well as the present at the baseline. Anatomical locations would be recorded. Laterality, directionality could be recorded as applicable to the lesion location. And sum of diameter has to be calculated for the target lesions that are identified. Upon follow-up visits, lesion measurements are recorded, and also the sum of diameter should be calculated for the same target lesions that were identified at the baseline. Sometimes reader might indicate images are not available. They might put the not available with adding a reason why it was not available. Also, the lesion state of the present or absence, or the pathologic or non-pathologic if the lymph node should be recorded. Sometimes the too small measure would be recorded instead of the actual size if the lesion becomes too small and the reader is having a hard time placing the actual size of the lesions. And in that case, default of 5 millimeter will be recorded and then calculated to the sum of the diameters. And here's some examples of the target lesions. In this example, I have a target lesion 01, which should be a target lesion ID with the location of the lung. Size is recorded as 27 millimeters with the tumor state present at the baseline. Also, lesion ID of the target lesion 02, location would be a lymph node, and then size would be both the long axis and then perpendicular short axis is recorded as a 24 by 17. Tumor state of the present, and the lymph node state of the pathologic is recorded for this particular lesion. And then the sum of diameter should be recorded or calculated, and then it'd be 27 plus the 17, which should be a lymph node of the short axis, adding up to 44 millimeters in this example. Non-target lesions would be any measurable lesions that were not selected as a target lesions, or any identified non-measurable lesion due to the size or truly because of the presentation type of the lesions. Anything that's remaining at the baseline should be categorized as a non-target lesions. And because of non-target lesions could be non-measurable, size measurement is not required to be recorded on the RECIST 1.1 form. Measurable non-target lesions still can have a measurement recorded as an optional. Also, for the special note on the non-target nodal lesions still needs a measurement to determine the pathologic states. If they are between 10 to 15, they would still fall under the pathologic state, and any non-target nodal lesions becoming smaller than 10 millimeters would be non-pathologic state. And here's some baseline and a follow-up examples of what data needs to be collected at the non-target lesion assessments. at the baseline, anatomical location, and the laterality. Directionality can be recorded. Lesion state should be recorded as a present for all non-target lesions, or the lymph node if pathologic or non-pathologic if they're lymph nodes. Upon follow-up, non-nodal should be recorded the state of the absent, present, or unequivocally progressed, and any nodal lesions should be recorded as a pathologic, non-pathologic, and also unequivocally progression. And sometimes the lesion can be not evaluable due to reader not possible to read the images, and definitely should record it with the reason not evaluable. And here's some examples of the non-target lesion images. And would be a non-target lesion number 1. And this is an example where RECIST also guides if there are multiple small lesions, they can also record multiple group of lesions under one lesion ID, such as multiple hepatic metastasis for the non-target lesion ID 01. For instance, on the second images, on a multiple lung metastasis, multiple lesions can be also grouped under lesion ID of 02 if the reader wishes to. And also qualitative assessment of the presence should be recorded. Upon the follow-up, new lesions always should be looked for. An appearance of any new lesions or new metastasis will be always assessed. For the non-nodal lesions, there are no size requirements for new lesions. And if any new nodal lesions, short axis should be greater than 10 millimeters. And also reader deems the nature of the enlargement is due to that malignancy. And the new lesion assessment, baseline would have no new lesions, and any follow-up, the state of the unequivocal or equivocal should be recorded. And if the reader answers equivocal, it must be confirmed in the next visit whether that lesion was truly unequivocal in the next time point. Measurement of the nodal lesions or optional as the other lesions if measurable. In lesion categories in summary, target lesion, non-target lesions, and new lesions are the 3 groups upon baseline tumor burden. Measurable lesions up to 5 and 2 max per organ would be go under the target lesion, and the sum of diameter would be calculated and assessed. And any of the measurable lesions remaining and non-measurable lesions, all of them would categorize under the non-target lesion group, and their qualitative assessment of the presence would be recorded. And these would indicate or represent the baseline tumor burden of that subject. In each time point, target lesion sum of diameter would be followed, and new lesion status of yes or no, and then also the non-target lesion, whether they have progressed or they disappeared or present still persisting, those will be assessed. And 3 of these assessment will come up to give a time point tumor response. So we can go a little more in depth of how to calculate or derive each lesion category assessment and how to calculate that the time point tumor response. Firstly, the target lesion response criteria would follow as this. There are 4 categories: complete response, partial response, progressive disease, and stable disease. 4 values can be assigned to, one of the 4 values can be assigned to the target lesion at that time point. Firstly, CR or complete response would be given at the target lesion level if the disappearance of the all target lesion occurs. Any pathological lymph node must have reduction in short axis of 10 millimeters. To give a partial response, at least 30% decrease in sum of diameter of target lesion compared to the baseline sum of diameter. For the progressive disease, if there is at least 20% increase in the sum of diameter of the target lesions compared to the smallest sum on the study, which is called a nadir. And also they have to also meet that an absolute increase of 5 millimeter increase. So 2 conditions should be met to get the PD at that time point for the target lesion level response. And for the stable disease is when it is not sufficient to qualify a PR or sufficient increase to call the PD, is the case where we would give the stable disease to the target lesion criteria. For the non-target lesion, there are three outcomes or the responses that can be given to a single time point for the non-target lesion level response. And that would be a complete response, which would be disappearance of all non-target lesions. Also, all lymph node must be non-pathologic in size, meaning 10 millimeters or less and in their short axis. And non-CR or non-PD, also known as an NN, is a persistence of one or more non-target lesions. Progressive disease would be given to the non-target lesion response criteria if unequivocal progression of the existing non-target lesions are seen. With knowing what the target lesion response, non-target lesion response, and the status of the new lesion is, we should be able to derive the overall time point response, which is a single value that's also given to that time point, and that value would represent how the patient is doing at that time point. And here's the general rule that's given from the RECIST 1.1. Target lesion is weighted more than non-target lesions. So if the target lesion is PR or SD, and the rest of the lesion categories are non-PD, target lesion usually derives the overall response, which should be a case of the line 3, 4, 5, and 6, where non-target lesions and new lesions are not indicating any progressive disease. The target lesion value becomes the same as an overall time point response, since the target lesion is weighted more and they have a more effect on reflecting what the overall time point response is. So one example is the partial response, and a non-target is NN, for instance, and there's no new lesions. Overall time point response becomes a PR, which is driven by the target lesions. Exception is when target lesion is CR or the complete response and the rest of the lesion category are not PD. Overall response is downgraded to the partial response, which would be, for instance, on a line 2 or 3, where target lesions are all disappeared, but non-target lesions are still persistent. Then the CR or the complete response is just simply downgraded to the partial response and the overall time point response. And to meet overall response of the complete response, all lesion category must meet complete response, which should be a first line. So all lesions has to disappear whatsoever so that the overall time point response can be complete response. And then lastly, any lesion categories meeting a progressive disease would result in overall time point response of PD. So our last 3 lines here, any of one of the categories becomes a progressive disease, that would automatically override the overall time point response of progression. So for instance, non-target lesions is a PD. It would not matter what type of value we would have for the non-target lesions or new lesions, we will automatically have a PD. And also any cases where new lesion presence would indicate a new metastasis, and that also automatically gives a PD to the overall time point response. And on top of the overall time point response that is given to on each time point, there is another response type that is called the best overall response. And this value or the response is a single value that is given to a subject as a whole. And this would be simply a best response of a subject during the study treatment. And this can be only determined once when all time point response of the subjects are known, starting from the baseline until the end of the study visits. And there is one additional consideration that we need to think about, which is called the stable disease minimum duration. And stable disease minimum duration is a duration that refers to as a randomization date or the first drug administration date to the duration or the date or the visit that we're trying to calculate the best overall response of the subject. And the reason that we're considering this is that there is a time that really takes the drug to come to an effect to show the tumor response. So we're requiring at least some time has to pass to claim that this response is really a drug effect, nothing really from the past treatment or any other biases potentially. So this is a SD minimum duration. And this is usually protocol defined duration. And commonly it is set to 6 to 8 weeks from the enrollment or the first day of the drug administration. And additionally, there is a concept of the confirmation of the response that we need to consider. And confirmation of the response is to make sure that response has been occurred, such as a CR or PR, and then confirmation has to be done to see that that response has been sustained for long enough. And in a randomized trial, confirmation of the CR or PR is usually not required. And that would also mean simply the best response across the all time points simply can be picked without any confirmation, which is a rather simple type of deriving a BOR without any confirmation needed. For the non-randomized trial, RECIST guides that confirmation of the complete response or partial response is required to avoid any biases. And usually those time frame for the confirmation is protocol defined and typically has to be at least 4 to 6 weeks. And the algorithm to determine what BOR would be with the confirmation should be incorporated, and which we'll be going over in the next slides. So best overall response confirmation can occur in this way per RECIST 1.1. And simply, this is to make sure that any response, which would be CR and PR, has occurred and sustained long enough, at least 4 to 6 weeks, to really claim that the drug benefit has sustained long enough to really say that the drug is working. First, CR or the complete response must be confirmed by another CR as a confirmatory scan to claim that the CR has been confirmed. Also, for the partial response, another partial response or the complete response should be seen at the confirmatory scan to be claimed as a confirmed PR. In CR or PR where the response is not sustained in a confirmatory scan is considered as a stable disease if the time of the CR or PR has met that minimum duration criteria for stable disease. If that minimum duration of the stable disease is not met on the number 3, then subsequent time point response must be considered. If there is no subsequent time point response available, that usually becomes a not evaluable. And for the number 5, not evaluable between responses are acceptable per RECIST 1.1 for confirmation. And this would also have a specific information in our bottom table here. In our example study, I would say minimum duration for SD or the stable disease is 6 weeks. And then we would also assume that confirmation of the interval has to be at least 4 weeks. And I have 5 different subject cases as an example to derive the BOR. In the first subject, I have a week 4 stable disease followed by a week 8 partial response, week 12 partial response, and week 14 stable disease. And in this case, we would find firstly what would be the best response is. And from these 4 responses, I showed a partial response is the best response. And next thing is just to make sure CR or PR has been confirmed in the next 4 weeks. which is a confirmation interval. So I show that week 12 has another partial response. So the week 8 partial response has been sustained through the week 12, and that has been confirmed by week 12 scan, so that we can claim that best overall response is a partial response. For the second subject, I have a week 4 partial response, followed by the stable disease, and stable disease. So first thing is I look for the best response, which should be a partial response. And I look for the partial response has been confirmed or not. And as I can see at the week 8, partial response has not been sustained at the week 8, which would be not confirmed PR. So this case, we would downgrade this PR to the SD. So our best overall response would be a stable disease in a subject number 2. In our third case, I have a stable disease, followed by partial response and partial response. In this case, I would also look for the best response first, which is the partial response. And I show another partial response in week 14. But in this case, confirmation interval of 4 weeks has not met for week 12 to the week 14. It's only 2 weeks apart. And this partial response has not been confirmed yet by this PR. So at this moment, I cannot really claim that the partial response has been confirmed. So that our best response would be simply a stable disease in this subject also. Our four subject, I have a stable disease, partial response, followed by not evaluable, and a partial response. And this would be a case where number 5 is applied to the RECIST 1.1. This would be a partial response and has a not available in between, and then have a partial response. In this case, we would claim per RECIST guidance that partial response has been sustained through starting week 8 through the 14th, which is more than 4 weeks, so that we can claim that the partial response at the week 8 has been confirmed at the week 14, so that we can claim BOR is a partial response for this subject. For the last one, I have a partial response at the first visit, followed by the not available in the rest of the visits. In this case, I look for the best response, which is a partial response at the first visit without any confirmation on following visits. So this partial response cannot be claimed as a partial, but also not enough to be called a stable disease, since the minimum duration of the 6 weeks has not passed at the week 4 point here. So unfortunately for this subject, our best overall response is not derivable or not available in this case. And a lesion response criteria in a whole, I have a short, simple example here. Would be in a multiple time point. I have 2 target lesions, 1 non-target lesion, and a new lesion status. So each of the target lesions would always have a measurement associated, so that the sum of diameter can be calculated. And at the non-target lesion level, each non-target lesions would be recorded with their qualitative assessment, which should be present or absent. And also new lesion status should be followed. So with these informations, we can calculate the sum of diameters, and then how much of the percentage increase or decrease has been occurred from the baseline or the nadir, so that we can calculate the target lesion response, non-target lesion response, and then overall response based upon those informations. Getting into a oncology trial imaging endpoints, there are 2 very common imaging endpoints that the RECIST 1.1 would directly be used, and which should be an overall objective response rate. This is defined as a proportion of the patients with the tumor size reduction of predefined amount and for a minimum time period. So basically, this would be a size reduction defined by RECIST 1.1, and that would be translated into CR, which is all disappearance or the 30% decrease or more. And basically, the ORR would be a proportion of the patient with the CR or PR of the best overall response. So all the information that's being collected through the RECIST 1.1 imaging read would translate into any responses, and deriving proper BOR would end up an accurate derivation of our imaging endpoint of the ORR in this case. For time to event endpoint, usually the progression-free survival is a common endpoint that the RECIST 1.1 outcome is directly can be used. Definition is the time from the randomization until objective tumor progression or death, whichever occurs first. And these tumor progression would be a radiologic progression date defined by a RECIST 1.1, commonly used for phase 2 and 3. And proper assessment of the progression date would be very important to actually derive an accurate PFS or the progressive-free survival. So these two common endpoints are something directly RECIST 1.1 would be affecting. Here's a quick summary or the how the response criteria and imaging endpoints are related. So assessing target lesion, non-target lesion, new lesions would derive a tumor response of the CR or PR of the best overall response. These two values goes into analysis of the ORR, and then a progression date or the progressive disease state would be directly used to provide a PFS with another different time to event analysis. This would be a quick summary of important RECIST reading for elements, which should be a individual lesion level information should be accurately collected, which should be also contributing to an accurate derivation of the lesion category level. And then also the subject level, which should end up in contributing to the imaging endpoint analysis. For the special consideration for RECIST 1.1, there could be a case where the target lesions are merging or splitting. And if the lesions are splitting, lesions should be recorded as a 0.1 and 0.2. They should be basically calculated or counted for how many fragments. For instance, if the TL02 splits into two pieces, the lesion ID would be labeled as a 2.1 and 2.2, and each of the individual pieces would be measured for their longest diameter, and sum of diameter would be calculated based upon that. If lesions are truly merging, the longest diameter of the one merged item should be measured, in which should be an example of the target lesion number 2 and number 3 are merging, and the lesion ID would become 02/03. And the sum of diameter would be simply measured for the combined lesion. And that length would be used to calculate the sum of diameter of that time point where the lesion merging has happened. Also, another common mistakes or the considerations to keep in mind for measuring a longest diameter is that the direction of the measurement is not something that should be kept consistent, but always have to find what the longest diameter is. And for example, I have a bottom example, which is the incorrect cases where the lesion measurement direction has been kept consistent, but truly it's not a correct measurement here, which is a 3.24 centimeter to a same direction ending up 3.22 centimeter. But actually in this scan, this direction gives the longest diameter, so that the measurement should be corrected to a vertical way more of. So that actually gives a 3.93, which is actually longer diameter than this one. And these incorrect or inaccurate measurement would actually possibly can cause inaccurate derivation of the target lesion response, for instance. Also, target lesion measurement, pair organ is considered as a one single organ. So lung or the kidney are the one of the examples. So when it comes to a max of the 2 lesions per organ conformance, both of the right and left is considered as a one whole organ. Also, for the lymph node, the lymphatic system per RECIST 1.1 is considered as a one organ. So if there are multiple nodal lesions that qualifies the target lesions, reader can only select up to 2 nodal lesions under the target lesions, and rest should go under the non-target lesions. Also speaking of the lymph nodes, complete response of the target nodal lesion does not always mean 0 millimeters, and that is due to the size of the node itself, which is a normal anatomical structure if the nodal lesion regresses without any truly malignant cells in it. So there could be a complete response with a non-zero sum of diameter due to the node that normalizes to less than 10 millimeters. Also, target lesion measurements with the too small to measure cases. When the target lesion becomes too small, radiologists will still have to measure and record the size in this way. So if the radiologist can confidently claim that the lesion has completely disappeared, then in that case, truly the measurement should be put as a 0 millimeters with just simple annotation on the skin of the arrow or the circle where the lesion would have been. If lesion is there and reader can confidently measure the accurate size, even though the lesions are really small, the number should be recorded and then be used to calculate the sum of diameter, whether it's a 2 millimeter or 3 millimeters, for instance. If radiologists see the lesion that is really small, but because it's too small and they're not confident to provide an accurate size on the form, then they should be recording a too small to measure. And by default, this will turn into a 5 millimeter placeholder value. And this 5 millimeter will be used to calculate the sum of diameter in that case. And for the cases where reappearance of lesion occurs, if the lesion reappears in the setting of the partial response or stable disease, where other lesions are still persistent, then reappeared lesions should be continued to be assessed without giving a progressive disease unless it truly needs a progressive disease. If lesion reappears after the complete response, then any reappearance of the lesions really indicates that the tumor response is the progression in that case. And some other special considerations on RECIST 1.1 would be a utilization of the clinical data. And one of the important clinical data at the baseline is that the prior radiotherapy information and a treatment location and date, and whether the progression has occurred since that treatment has been completed. And this is important since this information really dictates if those treated lesions should go under the target lesions or not. If any prior irradiated lesions has progressed since the treatment is over, then the reader may be able to classify that as under the target lesion if they wanted to. If those treated lesions has not progressed, and it should be not selected as a target lesion at the baseline. So these information should be information that's provided to the reader so that they can accurately select a correct target lesion so that the response can be derived properly and not being affected by any prior therapies. And another clinical data can be used to help the RECIST 1.1 would be a cytology or histology and biopsy in a specific circumstances. And these information can be used to differentiating a responses over progression. For instance, differentiating the residual mass from the true malignant lesion can be aided by a biopsy result. When radiologic assessment viewing the scan shows a very small residual mass, which could be a true malignant lesion or just remaining scar tissues, the biopsy result of the being positive or negative can really allow the reader to pick partial response to complete response. For instance, if the biopsy result of that small residual mass was negative, in that case, the partial response can be upgraded to the complete response, knowing that the small mass is not true malignant lesions. Also, sometimes differentiating expected side effect of the drug versus worsening of the disease possibly can be possible with cytology or histology information. When CRPO or SD is assigned to measurable lesions with worsening or appearance of diffusions or so. So cytology or the histology of being positive or negative can really assure whether those are responses or stable disease in case of negative versus any cytology result being a positive truly tells they should be progressive disease, not any possible side effect of the drugs. So additional clinical data is important for the reader to be really fine-tuning their responses and differentiating if radiology response and some combined clinical data should be utilized to give a right response or the progression to the subject. And thank you for the attention, everyone. And I will pass this to Shinji. Shinji will talk about MERIT for a short brief minute.
Thank you, Jean. MERIT is an innovative global clinical trial endpoint services provider specializing in ophthalmology, respiratory, oncology therapeutic areas. We provide end-to-end central imaging services from acquisition and upload to storage, QC review, blinded independent review, and data export. Our Excelsior software platform delivers automation in a single system for all image and workflow management that supports lesion measurement for various response criteria. We prioritize a partnership-driven approach for all projects and scalable solutions and personalized attention. MERIT CRO has more than 10 years serving biotech and pharmaceutical companies in clinical endpoint analysis and as an independent review center. We can work with therapeutic agents for solid and liquid tumors using modalities from CT, MR, PET. Our team consists of expert medical professionals, seasoned operational and project management teams. Together with our easy-to-use and intuitive Excelsior platform, we bring key advantages to support your clinical trials. Thank you, everyone, for your time today. We look forward to seeing you sometime in the future. Thank you.
Thank you.